I'm Kait Nesbitt, and this is The Rounds, a podcast where nursing professionals, community leaders, and nursing faculty share stories and practical advice for current and future nurses of all specialties.
And I'm Brooke Moseley, a nursing student here at Troy University.
Our guest today is a nurse practitioner, Justin Rigoloso. He has 20 years of experience in nursing and has the stories to prove it, including one where he carried a severed finger in his pocket.
He's worked in critical care and is a transport nurse in a helicopter. He's currently working in an emergency department observation unit.
He'll tell us why he became a nurse practitioner and how a new AI tool is helping him treat patients. What is ED observation besides, what's the difference between, our rural hospital's emergency department?
Sure. So basically, ED observation, I'm at a level 3 trauma center, which means we do not get any trauma. So with that being said, the ED observation unit, imagine if you could stay at an urgent care for about 2 days. So the ED obs unit is it was made to help decompress the ED. So it takes your lower acuity cases that need to be admitted to the hospital for about 2 days. So I see a lot of chest pain, TIA, GI bleeds, things that need. So it's kind of like the short stay unit, somewhere that you need to stay. The acuity is about like med surge, but it's somewhere where you're only going to stay for about 2 days, and a lot of that time is spent waiting on tests like MRI to come back. Things like if you have a GI bleed and you need an endoscopy, and then places where you just need a lot more frequent testing, like for chest pain, that's where we're doing the EKGs and the troponins.
So what drew you to ER and trauma?
So do you remember, this is a really long time ago, and Brooke, is your name Brooke?
Yes.
This was before you were born. The Learning Channel used to show actual educational shows instead of just reality garbage. There was a show called Trauma: Life in the ER, and it was on when I was I'd say maybe 10th or 11th grade, and it showed nurses. And at the time, I was kind of unsure of what I wanted to do. And I saw the role of the ER and the ICU nurse and the flight nurse. And I was like, that is something that I wanted to do. The thing about that type of nursing is it appealed to my blue collar nature, but also my love of science and wanting to help people. So I felt like that was a perfectly crafted job for me. And so I had a little bit of a non-traditional entrance into nursing in high school. I did health occupations careers, and I got my first job in the ER at 16 years old, which in hindsight was probably a bad idea.
I mean, introduced you early, but you probably have some trauma from it.
Well, then, you stuck with it, so something went right.
There's definitely a lot of trauma. I don't know why my parents thought hey, you know what? It'd probably be a good idea for our teenage son to be able to, to go see really gory things or naked women. In hindsight, probably wasn't a good idea, and I would recommend anybody else out there that's in that position to put aside a little bit of your paycheck for some counseling.
Yeah, that sounds about right.
So yeah, that's how I started, and I have loved it. It has been a great career so far, and I'm looking forward to probably about another 40 years in nursing at this point.
So we talked. You mentioned how you were you've been part of transport units, especially with on the ground. Have you ever been in the back of a helicopter?
I have. I did. So part of my role as a transport nurse, we did both.
Mm-hmm.
So we flew NICU infants and ECMO, and then we drove everything else. So it was about 80-20, 80 ground and 20% flight.
Oh my goodness.
My
NICU
ears just
babies.
perked up.
I loved it.
NICU's
So
small too. Stop
What's that?
NICU. I was saying NICU is small. I know NICU is like
Yes.
babies. They're
I
fresh.
loved it. Most guys, they pretty much fall pretty naturally into ICU and the ED, but we would fly 20-week-old infants, and I loved it.
Oh, Lord.
You see, and I never even thought about flying babies. The being on the bird has always been an interest of me, but I'd never even considered I might get babies.
You could
Well,
very well get babies.
I mean, I'm assuming that it takes some special certification, though, when it comes to transporting babies.
It does, but
It's a lot of
the
compressed
main
anatomy.
certifications I had was CCRN and CEN. But what my program did is they put me through NICU school. So I worked in the NICU for 6 weeks.
Oh, okay.
Now, granted, it's not like you're not like a traditional NICU nurse,
Mhm.
but they want you to get as much experience as possible. And a lot of that experience was just learning how to hold the premature infants and getting comfortable. And surprisingly, they're not as delicate and fragile as you would imagine. Now they're medically complex, but you would be surprised how hardy some of the NICU babies are. Because when you think about it, you're going to have a 2 pound baby. You treat it like a little like Christmas ornament. You're super afraid to touch it, but these NICU nurses were like, no, we want you to hold it. We want you to learn how to swaddle it. You're going to learn how to feed it. You're going to learn how to titrate drips. You're going to learn how to manage the vent on these babies. But the biggest thing is we want to encourage your comfort with these babies, and we want you to get in there and hold them and touch them. We want you to talk to the parents. We want you to change their diapers, and that actually was really helpful. The ICU stuff came naturally. Now, granted, it's a little bit different. Some of the pathologies are different. Some of the medications are different. But the biggest thing was getting over the fear of their fragility.
I think that comes also just like with babies, being a mom, like first time mom, I was so afraid, and also holding other people's children before becoming a mom. It was, how am I birthing this child?
Mhm.
How are they doing it? And then getting like kind of worried for kids because their parents are like, they look like they're whacking them to get the burp out,
Mhm.
and they're like, and they'll look at you and they're like, no, you need to go, you need to pound a little harder to help me out, and you don't realize it until you do it. That no, they first off they like it,
Mhm.
it helps calm them down.
Yes, that tactile stimulation, they really thrive on that. And they can kind of tell if you're afraid, they can kind of tell. I know that's not super scientific, but it kind of takes a firm, confident grip with the NICU babies.
Mhm.
I remember my clinical rotation in the NICU, and like one would cry, and they'd be like, "Go hold it," and I'm like, nope.
Yeah, yeah,
It's small, it's fragile." And then they're like putting in G tubes in, and they're doing this, doing that, and they don't. Not that they're just tossing this baby around, but they're not near as gentle as in my mind. You're supposed to be,
exactly.
but
And
I was
then they're
crazy.
like, "We want you to do this in front of the
But
scared parent."
yeah.
And I was like, "Okay, we can do that."
Mhm.
Yeah. I've been the scared parent, not in a ER situation with the child they're tossing around, but we had, my daughter had a blockage in her ear, and we had to, um, essentially restrain her so they could turn on a very loud machine and get the blockage out, and that was, like, jarring for me. Now she can't remember it. She was, like, 3 years old when this happened. She's very cusp of actually making memories, but for me, it was so jarring because I'm putting my entire weight on top of her to
Mhm.
hold her and hold her still, and the way the doctor was instructing the nurse to hold her head and, like, "No, you've really gotta grip her jaw. You've really gotta grip the top of her head and just hold her here," and I was like, I am y'all are doing great, but I will throw a punch if one of y'all talks about my daughter like that again." I was very thankful for them, but it was very jarring you because you also even though you live with them, you still treat them like little fragile ornaments
Mhm.
because 'cause they're delicate little girls. For me, girls.
They are.
Alright, I wanna shift gears a little bit, I guess, back to, like, your history as a nurse practitioner. How is, like, the scope of practice for NPs either specific to trauma or prescriptive authority, procedural, anatomy? Like, how has that changed over the years?
So for me, it was a little different. So I was educated. I did my NP in New York, and I did the adult gero acute care nurse practitioner, which
Mhm,
was pretty much it sets you up to go straight into the ICUs. Also in New York, most hospitals have like an adult and a kids ER and ICU. So That was pretty simple, but I didn't practice in New York. We moved. I graduated, and then we moved to Seattle, Washington, which is unfortunately a little different. They love the family nurse practitioner, so becoming a nurse practitioner in Washington was a little difficult. I couldn't work in the ICUs or the ERs because I can't see kids. So it was a very long journey to get my first NP job. I got my first NP job. My medical director on the ambulance had a spot open in his ED observation unit, but unfortunately, it was only part time. So getting NP work here with my adult Gero degree has been a little challenging. So, with that being said, in the ED obs, I don't have procedural abilities, unfortunately, but I do have full prescriptive privileges, and I don't require MD supervision. So, it's a little bit of double edged sword.
Yeah.
I'm not getting to do what I would really like to do, but I do have full autonomy, full prescriptive privileges.
So, help me out. What's the difference between just like a regular nurse and an AMP nurse practitioner?
So you're what we'd call a regular nurse, your registered nurse. There's, from what I know, there's pretty much two pathways that are still around. There's the associate's degree, which requires 2 years of college. And Brooke, you probably honestly know more about this than me. So I'd love for you to chip in. And then there's the bachelor's of science in nursing. That the educational requirements are a little bit different. Your bachelor's of science of nursing has more of your typical university education, where your associates is a little bit more focused on actual nursing. But with that being said, both of them graduate, both of them take the same state boards. In most places, they start entry level jobs pretty much at the same salary. Some places are moving towards requiring your BSN, and they have pathways to, if you are an associate, to receive your bachelor's. Brooke, is that pretty much the case for you guys?
That's what I've seen mostly here. I have friends that already have their associates and they're working full time as LPNs and getting a fast track actually to the MSN and kind of not necessarily bypassing the bachelor's, but you go straight through it. I'm going straight for my BSN and I plan to take 2 years off work bedside and go back for an NP after that, which I was glad you mentioned the family practitioner versus like the critical or even like leadership nurse practitioner. I never realized that there were some that didn't take pediatrics and adults.
There is. I would say do your due diligence, and really investigate what you will be able to do as a nurse practitioner, and also too, look around and see if there's ever a potential for a move for you. Look and see what the desired location, what their requirements are.
Yeah.
And also too, like, it really depends on the hospitals in your area. Here in Seattle, there's one big university hospital. Now, a lot of times that's where people want to go, and that's where I wanted to go. But you always have to remember too, your big teaching university hospitals, a lot of the quote unquote action is going to go to the residents, fellows,
Mhm.
and students. So unfortunately, what I've seen is they use the nurse practitioner as the in the role of a scribe a lot of times. So even if I was in the ICU, I wouldn't necessarily be getting the procedural experience that I wanted, because with the state hospitals, university hospitals, or teaching hospitals are dedicated to the training of the residents and the fellows.
Out in, like, Washington and everything, can a nurse practitioner have their own practice? Like, I know in the state of Alabama, you can pretty much have your own practice, like a family practice, but you have to have a doctor that signs off on everything at the end of the day.
Yeah, I think that's I now again, I should know more about this, but I don't. I think that's a federal requirement,
Mhm.
but I think that's true. Well, I'd have to double check, but yeah, that's pretty correct.
Okay.
And then also too, like, I would not suggest a new nurse practitioner go into autonomous practice,
Mhm.
because even being a 20-year nursing vet, the role transition was pretty difficult.
Can you talk more about that?
Yes, on my very first day, I was by myself with 18 patients.
Oh, wow.
Yeah.
Lord.
And they're like, here you go, have fun. And
Mm.
so like there's no direct oversight. There's no, there's maybe reach out and phone a friend, but like in the ED observation unit, the ED physician has signed off on care, so you can't really ask a lot
Mm-mm.
because they've already passed that patient off, they've handed off, and they've gotten busy and moved on. So yeah, I would definitely, and again, I would say this to nursing or to nurse practitioners, having a wealth of experience, not just knowledge, but having wisdom and maturity is going to be a huge benefit in whatever role of nursing you get into.
Never even thought about the difference of patient load. You go
I mean,
from
it
3 to
makes
4
sense.
to
It
yeah,
kind of makes sense. Like you're like an MP, you're signing like the first day, you're supposed to be the one who's
you're a
doing
provider.
everything. But I
Exactly.
mean, even in my world, there's still like within the first 2 weeks, somebody who's like double checking and making sure you're good, that your days are going fine, and you're not running into any problems. But I mean, in healthcare, y'all are swamped. At least in Alabama, we don't have enough nurses.
Mhm.
You
And so,
may have that. You may have the 2 weeks, but another unfortunate thing that I've noticed. Again, this is not science, but this is just something I've noticed. After COVID, there's been another reduction in the workforce. Another thing too is a lot of people have become burned out,
mhm.
and a lot of people, for whatever reason, I can't speak to whether this is a good or a bad thing, but have become pretty non-amenable to teaching. I think a lot of people were during COVID and a couple of the years after were really tired of working and having students and not being compensated for it. So it's been a really hard thing to find people who can teach, who can precept, who can mentor.
Mhm.
That's been pretty difficult to do. And unfortunately, I understand it. Um, but for me, part of being a nurse and one of the things I enjoyed the most was having students, being a preceptor. And yeah, there's going to be days where you're going to have to work and teach at the same time. For me, that was a great joy, but I can see how that is difficult and can put an extra strain on things.
Yeah, because you're having to both be the one in charge and the one who is handling everything, but you also have to take a minute at some point and go over that with. I mean, I don't know how to preceptor, but I would assume it's handle the situation as best you can if it's like an emergency situation, let's
Yeah.
say, and then stepping out and going over that. And that does take additional time that could be done on all of the other tasks that y'all are being asked
Mhm.
to do at the same time, all of the charting and updating family and like that does take at least one additional stressor of more time away from what you're already supposed to be doing.
Yeah, it is truly a skill and it is truly a patient endeavor to teach. Um, and I say that both being a preceptor and being precepted. It's difficult. Um, I think it's well worth it though, but it is hard to ask people to do two jobs for one salary.
Yeah.
All right, what this is a given that you kind of already get asked a lot. What's the most rewarding part of your job? And also just like what's the toughest?
Toughest part is, let me think. Do you want me to answer as a nurse or as an NP?
Either, whatever you comes to mind.
The most rewarding part of the job, I would say, was NICU because you obviously, well, I don't want to say obviously, you tangibly get to see the what you're doing benefits. Like the NICU families are always wonderful. They love you, they care for you, they are 100% invested in the health of their child. So I always felt like I was doing good with the babies. Like that everything you do is appreciated. Um, Patient interaction is something I've always enjoyed. Um, One thing I did get to do when I was doing transport is we also did like a form of home health. So you got to go into the patient's home and you got to see them live their everyday life. which was very cool. You don't get to see it all out in the hospital. So I'd say like the patient interaction is the most rewarding. The most difficult part is the parts of healthcare that you don't see, like healthcare administration, finance, billing, um, the more of the bureaucratic things, the things that you just don't understand and you don't see, like the rules and regulations that exist, and you're like, I could tell this was made by someone who is not at the bedside. Those are the hard parts.
Do you have any like strategies you use when it comes to like interdisciplinary conflicts between physicians and nurses or patient family members? Anything that kind of comes to mind there?
I think something you got to remember is unfortunately there are people that just do not have good interpersonal and or coping skills. So sometimes you can't take everything personally. Unfortunately, there are bad actors. There are people that do malicious things. Sometimes that's part of it. And sometimes you got to let that roll off your back. I think it's always a good idea to be direct and clear as much as you can. Be specific when talking, or when especially like with now texting is like medical texting. Take that extra time to be clear. Spell it out. Be diligent when you communicate. I think that's a great way to try to prevent a lot of conflict in the first place. Something that I've used before as a nurse, it was a phrase I used it a lot when I was in charge, um, and I'll talk you through it by what I mean. Is like you would have a lot of people that are upset, and something I would say very directly is, I understand that you're upset, but what exactly is it that you want me to do right now? It seems a little curt, it seems a little too direct, but if they tell you something, then you can say like, okay, well, I can work towards that, or I'm sorry, that's not something we can do. What else could I do for you? So take
Mhm.
that time to be clear, be direct, be diligent and specific, and I think a lot of times that can help. And again, also know at the same time that unfortunately some conflict can't be resolved. You are dealing with people that are upset, angry, hurt. You're going to have to go into it knowing that sometimes you are going to be disrespected, and sometimes you have to be the bigger person. And I hate saying this, but you got to be the bigger person and suck it up and just absorb it sometimes.
Don't take it to heart, but be straightforward when you're saying stuff. Yeah.
Yeah.
So you talked about medical texting. Is there any other like technology machines or apps that have kind of been added throughout your career that have really brought some benefits?
Yes. Open evidence. It is the medical version of ChatGPT.
What?
Yes, love it. Super helpful.
We might have to have
And
you on again
ChatGPT
just to talk about that.
Yep.
and ChatGPT, I use a lot. Open evidence is a little bit better because it has like Open Evidence has access to JAMA, New England Journal of Medicine, a lot of your journals. Chat GPT, you have to train a little bit.
Mm-hmm.
So something if there's something I'm super unfamiliar with. Okay, so I had a patient with celiac disease. I don't know anything about celiac disease. So I could literally type into Open Evidence, um, what's my medical decision making for celiac disease? So it'll talk you all the way through it. Chat GPT is good, but you have to train it a little bit. Like you specifically have to say, make sure that responses are from New England Journal of Medicine, because it'll give you some non-medical stuff,
Mhm.
and then over time, Chat GPT will learn it and will tailor your requests to a more medical fashion.
Interesting.
Now, granted, you have to do your own research and you have
Yeah.
to verify it, but it's super helpful.
It's like
That's
a
amazing.
medical Google,
Well,
sounds
yeah, I mean,
like.
I think of ChatGPT, and almost like, really front-facing AI software that, is beginner friendly. I mean, it's to give you, like, this is how helpful it can be, but I do think that there's an instant where you need to, like, definitely have this different tool that
Mhm.
does that, but it's more specialized. Like,
Mhm.
you wouldn't be going, I'm guessing, to Open Evidence and asking it to tell me how to
How to
change the oil on my
ask it how to bake sourdough.
how to bake sourdough, because it just won't have that information to pull from. But I mean, you're right. Having the human brain is fantastic, but you can only hold so much. And you're going to have all these rare things coming across. Not all, but you're going to experience stuff that you don't specialize in, but you don't want to provide any sub-quality care. We're going to have a whole episode on AI. I'm telling you, I love talking
You're
AI.
coming back, apparently.
Yeah. I'll have a panel of people. You'll be a part of it.
I'm probably but what's funny is like I'm not a technology guy at all. And so when my friends say like, do you use GPT or AI? It's like, yeah, I use it a lot. And they're like, you're kidding. But yeah, it is a great tool. Now, granted, I think in time there will be some problems with it. Like you can get very dependent on it. You can get lulled into non-thinking and just be like, oh, I'll just, chat GPT it or open evidence it. It doesn't replace clinical skill. It doesn't replace, wisdom by any means, but I would say it's a good adjunct to your practice, whether you're a nurse, whether you're an NP. And open evidence, I think, is one of the more premier ones. It's free for medical professionals. I think students can get it as well.
So to please my trauma happy heart over here, without violating any HIPAA or anything, can you give us one of your favorite stories or most interesting cases or anything along those lines?
Okay. When people ask me this, they always want to hear the gory stuff. I'm going to give you a really feel-good story.
Okay, I love it.
Okay, so I would say this is probably around 2015. I was working in the ICU. I was doing oncology ICU. And so we had a young man. He was coming in I think he was upper stage testicular cancer. He was coming in for his cancer surgery. They were going to remove the cancerous tumors. And unfortunately, they had to remove both of his testicles. So, unfortunately, this guy had a pretty heavy drug and alcohol habit. It was rumored that he used drugs and alcohol right before he went into surgery. So, he went into surgery. Surgery was successful, but he was in the ICU due to like horrific drug and alcohol withdrawal. And so this guy got out of bed. He was super violent. He was literally hitting nurses. I had to come in and break up a fight between him and the patient. And this happened for a couple of days. His withdrawals were horrific. So a couple days later, he gets transferred off the unit. We never hear from him again. 6 years later, I'm in the ICU, and this guy comes up to me and says, "Hey, are you Justin?" I was like, "Yeah, I am." He's like, "Were you ever a charge nurse in this ICU?" I was like, "Yeah, I was." And he came up to me and said, "Hey, I wanted to come up to you and tell you I'm sorry for everything that I did. I wanted to let you know not only is my cancer in remission, but I've also been going to 12-step programs, and I'm X amount of days sober, and I'm working my 12 steps, and I wanted to come and say I'm sorry for what I did, and apologize to you." And I was like, "No way. I do remember you." He's like, "Hey, I'm sorry." He didn't give an excuse.
Mm-hmm.
He just said, I'm sorry, full stop. What I did was wrong." He said, "Hey, my cancer's gone. I'm eternally grateful for you guys for doing that. And I've decided to get clean." And he'd been sober for quite a while. And that's one of those days that really restores your faith in humanity. And it kind of helps you remember what you see in front of you is not always the full story. We don't always know the backstory, but we don't always know, the story going forward. So it was really a feel good story.
And you also don't know how much you affect someone because, like, those programs, while yes, they are encouraging you apologize to everybody, he'd have to remember that after 6 years
Yeah,
from seeing
that
you.
dude went back and apologized in person, face to face, to as many people as he could.
It also just gives you the extra, like, this is why I do this, to help people. And
And then
you never know
also,
what's going to come out of it.
you don't. And then I had so much respect for that guy because, like, he might have to face some people that he really angered.
Mm-hmm.
And he might have to sit there and face the consequences of what he did. Like, forgiveness is not always mandatory, it's optional. And I wonder if people gave him a hard time or if people really expressed their anger about things that he'd done inside and outside of the hospital. But I was like, wow. So that's one of my better stories.
Oh, that's awesome. I'm so
That
glad
did
you
pull my
shared that.
heartstrings a little.
Yeah. And I was like, wow. Like, so you never know. Like, you never know what impact you make. You never know the rest of the story. So, yeah, that's a good one.
And I would like to know, is there any advice you'd give that current nursing student who's wanting to be either ER nurse or a future nurse practitioner, anything along the lines? What advice would you give them?
I have so much. I have so much, but I am going to give you a little bit of I am going to tickle your fancy a little bit. I did have a guy who I had to transport. He was at a rural hospital. So a lot of our job was going out to rural hospitals and getting patients and bringing them back to level one or specialty services. I took care of a guy that got drunk and cut his finger off. And I had to carry his finger in my pocket.
In your pocket? You could put that in a glove or something?
Well, yeah, it was in a Ziploc with ice. Like it's
Oh,
not like
okay.
raw dogging in my pocket.
It's like it's just in your pocket. Okay.
No, so I had his finger. It was packed. It was like wrapped in gauze and packed in ice, and I had that in my pocket because you're not going to put that in the cooler. That's dumb. So and then every once in a while he was back there and he was pretty well sedated. He would giggle and be like, "Is that a finger in your pocket?" And I would just re-sedate him because it was pretty frequent. We gave him ketamine. Pretty standard for trauma, and that can make people a little loopy. And so he would just giggle and be like, is that a finger in your pocket? And I'm like, yep, go to sleep.
So just so we're clear, the advice you're giving our nursing student is
Be willing to keep a
is
finger in your
use-
pocket.
make sure the finger goes in your pocket and give them ketamine.
Well, no, I have actual real stories, but I do like to joke with my patients. And so every once in a while when he would wake up, I'd be like, weird, man, why do you have like a black ring finger? And he'd be like, what? No, I have lots of legitimate advice. Number one, the nurses of old used to say this, and it holds true today: treat the patient, not the monitor. Um, don't treat isolated data points. Don't treat a single data point in isolation. What I mean by that is, if you have what appears to be a perfectly healthy patient, does not appear to be in distress, they're speaking in full sentences, they're non-cyanotic, don't trust when the O2 sat says it's 82. That's treating a variable in isolation, not taking into account the whole clinical picture. Things like if you have a white count of 15, but you're not fever, like you're not febrile, don't automatically think of infection. Does that make sense?
Mm-hmm.
Look at the whole picture, and don't get don't get lulled into a sense of safety or distress just by numbers on the monitor.
Yeah.
A number is just a number until you have an associated sign or symptom.
All right. Well, thank you so much for joining us. I look forward to speaking with you again, and really appreciate everything you've talked with us today and all the questions you've answered.
Anytime. If I could be helpful to you guys in any way, let me know. Kait, email me, reach out, whatever you guys need. If I can be helpful, I'd love to be an asset to you.
Absolutely. Thank you so much for coming along.
Guys, you're welcome. Thanks so much.
Well, we've come full circle on this episode of The Rounds. We want to thank our guest, Justin Rigoloso. But before we go, don't be afraid to press that call button. Record a voice memo with your question for our guests and send it to kross120311@troy.edu. It can be anything from, how do I get started in nursing, to why does it hurt when I do this? Quick disclaimer, nothing you hear on The Round should be considered medical advice. If you have a serious medical question, please ask your doctor.
You can stay up to date on new episodes of The Rounds by subscribing on the podcast platform of your choice. And be sure to share with the nurse or nursing student in your life. The Rounds is recorded in the studios of Troy Public Radio and is produced by Austin Toy, Kait Nesbitt, and the College of Health Sciences at Troy University.
So, until next time, I'm Kait.
And I'm Brooke.
We'll see you again next month when The Rounds returns.